Welcome to the lecture on mechanical ventilation. The majority of this topic will be covered in this presentation, with some review in the classroom. So, here goes. There is some terminology worth reviewing as I begin to talk about issues with normal ventilation and artificial ventilation. The first term is the tidal volume. Tidal volume is defined as the amount of normally inspired air in and out. This excludes that bigger deep breath that you might take, like when you're taking a sigh, and forced expiration. When on mechanical ventilation, it is calculated at about 5 to 8 milliliters per kilogram. We are all different, and therefore our ideal tidal volume is typically calculated by weight. The FiO2 is the amount of oxygen that is provided to the patient, either through room air ventilation at 21% or through supplemental oxygen administration. To prevent oxygen toxicity, the goal is to provide the lowest FiO2 possible to be able to maintain the ordered oxygen saturation, typically greater than or equal to 92%. For a patient with ARDS, the goal would be greater than or equal to 90%. Oxygen toxicity can alter capillary membranes, and you know from the inflammatory response, this can be very detrimental. On mechanical ventilation, the rate is also set. I will address that in a bit. During normal ventilations, we spend twice as much time exhaling as we do inhaling. Therefore, the inspiratory to expiratory ratio is named as 1 to 2. In patients who have stiff lungs, such as ARDS, ventilator settings are set so that there is more time for inhalation in an effort to improve tidal volume and therefore gas exchange. This is generally uncomfortable for the patients, so they often will need to be sedated, as it's not comfortable to inhale for twice as long as it takes to exhale. Give it a try if you doubt me. Normal breathing is based upon negative ventilation, and air and gases are moving along a concentration gradient, moving from an area of higher to lower concentrations. Therefore, when assisting patients who have ventilation issues, positive pressure ventilation may be used, often going against the concentration gradient. One complication of positive pressure ventilation is that it increases intrathoracic pressure, putting pressure on the vena cava, thereby decreasing preload. Careful monitoring of blood pressure is extremely important when initiating this form of ventilation, and this includes PEEP, which we're going to discuss later in this video. Actually, we're going to discuss it right now. Whether the patient is on invasive mechanical ventilator or using non-invasive means of assistance such as CPAP or BiPAP, the theory is all the same. Alveoli remain open during exhalation. This allows for an increased surface area which improves gas exchange. I am going to begin to talk about mechanical ventilation with invasive mechanical ventilation. Here are just some of the reasons why invasive mechanical ventilation will be initiated. It all has to do with compromises to ventilation and the need to improve gas exchange. Unless the patient has a tracheostomy, an endotracheal tube will need to be inserted for mechanical ventilation, either through the nose or through the mouth. Most commonly, it is placed in the mouth, unless contraindicated. Similar to a Foley catheter, there is a cuff at the end of the tube, which is very beneficial. First, it seals off the trachea. Therefore, air entering the tube cannot escape around the tube. The full tidal volume should then be delivered to the lungs. The cuff also assists the tube to remain in place. And lastly, the cuff protects the airway should the patient aspirate gastric contents. The cuff pressures are checked often by respiratory therapy, as maximum volume delivery is key. The tube has a radio-opaque line on it that is detected on the chest X-ray to help assess tube placement. This is a nice example of tube placement below the level of the vocal cords. The trachea is marked with the letter C. The esophagus is marked with a D. Also, once the tube is placed, the ideal position for the bottom of the endotracheal tube is about 2 to 3 centimeters above the level of the carina, or where the trachea divides into the two bronchi. There are universal adapters on the end of the endotracheal tube that fit with the end of the ventilator tubing, as well as the bag valve mask. For patients who inadvertently extubate themselves, a mask should be readily available to attach to the end of the bag for the nurse to ventilate the patient if they are unable to maintain their own ventilations. This is why it's important to always go into your room and check and make sure that there is a bag valve mask available in emergency situations for each of your patients. The size of the tube needs to be taken into consideration prior to intubation. A tube that is too big can cause ischemia in the trachea. If the tube is too small, there is resistance to airflow that will compromise the tidal volume. An oral airway may be used in conjunction with the tube if the patient is not well sedated and they bite on the tube, which will also compromise ventilation. The size of the tube needs to be documented upon insertion. The internal diameter of the tube is documented in millimeters. So if a patient had a size 7 tube inserted, it is 7 millimeters in diameter. Where the tube sits on the lip line also needs to be documented by the nurse, as this helps the caregivers monitor the position of the tube. It is documented in centimeters. So if you look at this picture and you check the lip line and you note that the ET tube is at the 22 centimeter mark, you would want to document that and pass that on in report. The nurse following you would also want to verify that the ET tube is still located at the 22 centimeter mark. If not, it is either pulled out a little bit or it is going a little bit further down the trachea. ET tubes cannot be left in indefinitely, and a discussion will take place with the patient's family and the physicians regarding a tracheostomy if the patient still requires airway and ventilator support. Hopefully, the patient will only need temporary support and can be extubated in a timely manner. Once the tube is removed, the nurse needs to be vigilant for possible laryngospasm. This is more likely to happen if the patient inadvertently pulls the tube out and the cuff is still inflated, and this does happen. As with any tube that is inserted into the airway, the cough, gag, and swallowing reflex need to be assessed prior to feeding the patient or allowing them to drink the following tube removal. When intubating a patient, the person who is doing the intubating may announce that they can visualize the cords as the tube is passed through them. Once the tube is placed, verification will take place in 2 ways. Initially, while we wait for the chest X-ray to be taken, an end-tidal carbon dioxide monitor will be placed. The readings should reflect that the tube is in fact in the trachea, because expired carbon dioxide is being measured. The esophagus does not expire carbon dioxide, so if carbon dioxide is not detected, the tube is in the esophagus and it needs to be removed. But the gold standard, the end-all be-all placement verification for an ET tube is a chest X-ray. All other methods used are subjective assessment findings and can be very unreliable. The picture on the left is a quick and dirty indicator that will change colors when in the proper place. The second picture is more of a permanent fixture, like a monitor. The yellow line indicating 40 millimeters of mercury is the measured carbon dioxide level. Post-extubation, the nurse needs to constantly assess the patient to see if they tolerate being off the ventilator and can breathe efficiently on their own. Not just their ability to ventilate, but also to exchange gases. Vital signs need to be assessed very carefully. Does the patient look like they are struggling? Are they tiring out? Do they look like they are in respiratory distress? Are they changing their level of consciousness? All of these may indicate that the patient needs to be re-intubated. Let's move on to the ventilator itself and the modes. The CMV mode, or controlled mandatory ventilation, is very rarely used. There is a set tidal volume and rate. The patient is not assisting the ventilator and more than likely is not able to breathe on their own. With assist control, the rate and tidal volume are set, but the patient has the ability to breathe faster than the assigned rate. In this mode, if the patient initiates their own breath, the tidal volume will still be controlled by the ventilator. You may see something like the numbers you see on the slide. The preset rate on the ventilator is 12 breaths per minute, but the patient is breathing 20 times per minute. They are assisting the ventilator. This is one of the most common ventilator settings. With SIMV, or synchronized intermittent mandatory ventilation, the rate on the ventilator is more than likely set a bit lower, and when the machine delivers a breath, it is at the set tidal volume. But when the patient initiates their own breath, the tidal volume will not be delivered by the ventilator, but rather it will be the patient's own tidal volume. It is time for the patient to begin strengthening their respiratory muscles and take over more of the work of breathing. So often when they're thinking about extubating the patient, they'll switch them to an SIMV mode to see how they tolerate initiating their own breaths and what kind of tidal volumes they can pull. PEEP, or positive end expiratory pressure, is added to keep alveoli open at end expiration. Because the alveoli stay open, it is suggested that the tidal volume be decreased to prevent barotrauma. Barotrauma is a pneumothorax that is caused by too much volume in the alveoli and they rupture. So think about blowing up a balloon too big and it pops. That's barotrauma. This is one cause of what is termed a secondary pneumothorax. As stated previously, increasing the PEEP decreases preload and can compromise the cardiac output. PEEP is usually set anywhere from 3 to 10 centimeters of water pressure. The last mode I want to talk about is pressure support. These patients are ready to be extubated, as they are supporting their own respiratory rates and tidal volume. But the machine is still keeping the alveoli open to support gas exchange. In this mode, the patient cannot be heavily sedated. Speaking of sedating patients, being on a ventilator is anxiety producing. Think about doing all of your breathing through a straw and how that might make you feel. The tube can cause the patient to gag. It is uncomfortable. The patient cannot communicate, and there is much oxygen consumption when the patient has anxiety. Therefore, it is important the patient remains sedated while on mechanical ventilation. But the goal is not to snow the patient or oversedate the patient, but to assure that they are calm and easy to arouse. It is referred to as light sedation. Propofol is a short-acting anesthetic with a short half-life. Precedex is an alpha-2 agonist, so some side effects are hypotension and bradycardia. The beauty of this drug is that it is an anxiolytic, anesthetic, and a hypnotic, and is actually preferred more often these days than propofol or some of the neuromuscular blockade medications, the IUMs. In certain situations like severe traumatic brain injuries, the goal is to reduce oxygen consumption. Neuromuscular blockade drugs will paralyze the skeletal muscles in the body, but will not change mentation. Therefore, with this mode of treatment, so if the patient is on not ipratropium, pancuronium, then they will also need some sort of sedative medication as well. Look for the IUM suffix. Knowing your patient needs to be intubated and ventilated means that the right equipment needs to be at the bedside so you'll have it as you need it. This is especially true of the manual resuscitation bag and mask that should the tube inadvertently be pulled out. Also, if the patient codes, the bag will be there to manually ventilate the patient. Keep a portable oxygen tank under the bed or somewhere in the room, lest you need an alternate source in case of emergency. The machine should be plugged into the emergency power source receptacle should power be lost unexpectedly. They are typically red power receptacles. The nurse also needs to be aware at all times of what the last ordered ventilator settings are and to verify that by checking the machine. Assessment of the patient on invasive mechanical ventilation then is still all about the ABCs. Your primary job is to maintain that airway as the patient is unable to do so on their own. That means assuring that there are no kinks in the tubings. The tube has not moved from its original position on the lid line, and the patient gets suctioned when secretions begin to obstruct the airway. Monitor the ventilation and oxygenation status. What is the patient's respiratory rate and heart rate? Are they tolerating the ventilator? What is their work of breathing and breath sounds? What is their end tidal carbon dioxide and pulse oximeter readings? And in circulation, especially if the patient is on PEEP, what is the blood pressure? Are they in pain? Do you see them grimacing? You want to see that they are pink, warm, and dry. To prepare to suction the patient, the nurse needs to be aware of several baselines. What is the pulse oximeter prior to suction? The patient should be hyperoxygenated for 30 to 60 seconds prior to the procedure to prevent hypoxemia. What is the baseline cardiac rhythm if on a monitor? If dysrhythmias present themselves during suctioning, the patient is more than likely hypoxic. Stop the procedure and hyperoxygenate the patient. As you have learned in the skills lab, suctioning should not last longer than 15 seconds. The lowest possible suction setting should be used to prevent trauma to tissues, usually no more than 100 millimeters of mercury. What is the appearance of the sputum and all of the characteristics that could indicate an infection? What were the lung sounds before suctioning and what were they after suctioning? After suctioning, also reassess all of the vital signs and lung sounds. In January 2014, one of the national patient safety goals, hospitals were required to have policies and procedures in place to manage alarms. This included acceptable parameters and who has the authority to change alarms. This pertains to all alarms used for patient safety, which includes mechanical ventilators. No alarm should be ignored. There are 3 that I want to mention. The first one is the high pressure alarm. The ventilator is attempting to deliver a set tidal volume under a set pressure, but is meeting resistance. The alarm will sound. Does the patient need to be suctioned or is there a mucus plug? The patient on mechanical ventilation usually has an NG tube in place. Does the tube feed need to be irrigated? If the patient is receiving enteral feedings, is there a large residual? A full stomach will push up against the diaphragm and increase interthoracic pressure. Is the patient coughing and what we call bucking the ventilator? As there is counterpressure. Are there any kinks in the tubings? Another thing to consider is that these tubings have humidification in them and it can accumulate in dependent areas. So it's not unusual to have areas where there's a lot of water accumulating in the tubing, which can increase the pressure and cause the high pressure alarms to go off. Assess the breath sounds. Was there a sudden episode of bronchoconstriction or a new pneumothorax? Have the lungs suddenly become less compliant? These are all things to consider. A low minute volume alarm is much easier to assess. There is a less than desired tidal volume being delivered. Is the patient hypoventilating when on SIMV and they need setting adjustments? Is there a leak somewhere in the system, or is there a tubing that is disconnected? So low pressure alarms, a lot of times it's a disconnection of tubing. Okay. The apnea alarm probably should have been first. The apnea alarm is pretty important. You will be running to respond this one. It is pretty high pitched, so if the apnea alarm goes off, you need to run. Patients who are ready to wean take over most of the work of breathing prior to extubation. They may move from assist control to SIMV, something called a T-piece or spontaneous breathing trial. Prior to the attempt, the respiratory rate should be less than 35 breaths per minute. The tidal volume should be greater than 5 milliliters per kilogram, and the oxygen saturation at least 90% or better. Patients who will have a difficult time being weaned are those with impaired neurological status, heavy sedation, increased secretions, a weak cough, a hemoglobin less than 10 grams, think about oxygen carrying capacity, advanced age, and those with multiple comorbidities, especially lung disease. Something called terminal weaning involves a discussion far in advance of having to make the decision to remove a patient from the ventilator when they are unable to maintain their own ventilations. In terminal weaning, the patient will be extubated and given medications for comfort and to ease the work of breathing. There are many complications to being invasively mechanically ventilated, but I will stick to the main ones. Ventilation-associated pneumonia is one of the most significant ones. It is a nosocomial infection and can be prevented by meticulous nursing care. Suction only when needed to prevent opening the system. Frequent oral care is paramount. Elevate the head of the bed at least 30 degrees at all times. Ensure adequate hydration to keep the secretions loose. And maintain ulcer disease prophylaxis, such as proton pump inhibitors or H2 blockers. It is sad that I have to remind nurses to wash their hands before and after each patient contact. Ventilator-induced lung injury is also known as barotrauma. The alveoli have become over-distended and rupture, causing a pneumothorax. This could be the result of too high tidal volumes or pressures. Frequent lung assessment is key, and collaboration with respiratory therapists. In past slides, I have expressed this, with decreased preload and cardiac output secondary to PEEP. You may not think that communication or lack thereof is a complication, but the patient who cannot speak cannot communicate their needs, and that could be an issue. Here's an example of a tool that can be used to help with communication. Finally, let's move on to the spontaneously breathing patient who requires non-invasive positive pressure ventilation. There are two modes available, CPAP and BiPAP. CPAP delivers one continuous positive pressure during inspiration and expiration, whereas BiPAP typically delivers a higher pressure during inspiration and a lower pressure during expiration. Both require a tight seal to maintain the pressures necessary to keep the alveoli open, as well as keeping the tongue displaced for patients with sleep apnea. These devices can be very effectively used as a bridge to assist patients while emergency treatment is occurring and possibly to prevent intubation, especially with those patients who have a lot of comorbidities. A good example of this is in patients with acute pulmonary edema. While they are actively diuresing, these devices with the increased pressure being forced into the alveoli can push fluid from the alveoli back into the pulmonary capillary beds. Because they are positive pressure devices, they can also decrease preload and cardiac output, so the nurse needs to monitor the patient for this. Mucous membranes can dry out easily, so oral hygiene needs to be performed and the patient well hydrated if there are no contraindications. Care needs to be taken to protect for pressure ulcers as these seals are very tight. The patient must be able to maintain their own airway as vomiting can occur if the stomach becomes overdistended due to use. The head of the bed then should be elevated to prevent aspiration. As the condition allows maintained nutrition, the mask can be temporarily removed to allow the patient to eat. While eating, the nurse can supplement the patient with oxygen through a nasal cannula. Because of the potential of dry airways, the ability to swallow needs to be closely monitored. This concludes this portion of the presentation. If you have any remaining questions, please seek assistance from your instructor. Thank you very much for your time and attention.